at Epworth Healthcare and Peter MacCallum Cancer Centre and part of the Snowdome Foundation. And this is the third webcast that I've done to talk to patients about the coronavirus and COVID-19 in the context of patients who have blood cancers. So welcome everybody who's joined us previously. I just would comment that I'm wearing my College of Pathologists tie, proudly given to me by Eva from the College of Pathologists, who is spreading the news amongst her colleagues and patients and carers. So what I thought I'd talk to you about today was a little bit about some of the terminology that's being used around the future and how we're going to manage COVID. So the first thing I want to say is the concept about shifting the curve. So what the shifting the curve means is to try and stop the onslaught, a large number of patients being diagnosed with this condition, overwhelming the health system, and patients developing serious illnesses and ending up in intensive care. The downstream effect of that is a lot of virus in hospitals, hospitals literally getting infected so that there's a high incidence of infection in the hospitals, and then healthcare workers getting infected. Thanks Eve for joining us. You like she notes the tie's looking good, and a lot of people getting infected. And a healthcare workers getting infected. And so this is what has happened in Italy and in Spain, and to a lesser extent in the United Kingdom, where there was a high influx of the virus with lots of patients. The learnings from that has been to try and undertake all of the precautions that the government has put into place. And what that means is that fewer people can infect other people. On average, one person with coronavirus will infect 2 other people. There are some people that have infected up to 9 or 10 people, but generally it's 1 infects 2, then those 2 people infect another 2, making 4, etc. So it can move quite quickly. But if there is appropriate social distancing, then those people cannot then infect. And that's what we're seeing with the reduction in numbers. So now we're down to consistently less than 50 patients being diagnosed a day in Australia. In a population of 28 million plus, that's a low number. So we've got to stop more infections coming in, and that's fundamentally what closing the borders means. And so if we continue to close the borders and we reduce the number of infections that are coming here in Australia with social distancing, the numbers will go right down and potentially as close to zero as possible, very close to zero. Now that means that there's great hope for all of us here in Australia with patients that are at risk. And so that may then mean loosening off some of the restrictions. So what does that mean to patients at the moment? Don't change anything now. Don't become blasé. The virus is still out there. It's going to occur in pockets. You don't want to be those pockets. And because your patients coming near hospitals, obviously patients with the potential COVID would be attracted to hospitals to get treatment, etc. So numbers are low, but don't change anything. Ultimately, the distancing will get less. In that situation, we have to ask ourselves, what do we do as patients at risk? That leads to the next question: who is at risk? And the answer is that we don't really know who are the major patients at risk other than the severely immunosuppressed. I've been talking to colleagues overseas, and the thrust is that there's no single population that seems to be at super risk, in addition to the other major risk factors of age, comorbidities such as diabetes, kidney disease, lung disease, heart disease. But blood cancers per se, myeloproliferative diseases, monoclonal gammopathies, myeloma, lymphoma, patients are at a risk, but it's not an enormous risk, and it needs to be put in the context of the general population. So as the social distancing lessons, you should be able to move into the community as well, and you don't need to overly protect. I think one of the questions that will come into relevance is the use of masks. It remains very controversial. It's fair to say that masks do work, but they there's been a limitation in access. When masks become more generally available, we may undertake the principle of doing more masking. And I generally say to my patients, seriously consider it. It certainly stops you touching your face. People are aware, they keep their distance. It has some other advantages, and it does reduce the load. So I think as we move out into the community, as these loosen off in the next month or so, then you should consider and ask your doctor whether you should be wearing a mask, and I think it's very reasonable to consider it. People are talking about treatments out there, and what does that mean? People don't actually understand clearly what does treating the disease. So it's not a treatment like we would treat a pneumonia or a bacteria. Bacterial infections can be treated with antibiotics, and that kills the bacteria. So if you have an infection in the skin, cellulitis, you cut yourself on a thorn, you can get an antibiotic and it will treat the disease, it will get rid of the bacteria. We cannot do that with coronavirus. What they're talking about treatment is to try and treat some of the collateral damage that this virus does. So once it gets into the chest, it can induce a significant inflammatory response. If any of you have had the flu, you feel achy, you feel pain, you feel like you don't want to get out of bed, you lose the energy, and that's because your body is inflamed, setting up a scenario where it's trying to kill the virus, and that makes you feel rotten. Now, in coronavirus, in some patients, that's an overactivity, and there may be other drugs that can be used to suppress the immune system. So, for example, hydroxychloroquine has been talked about, which is a drug that's used in rheumatoid arthritis. That seems to maybe have a role. Other drugs that you'll hear about, some of the drugs that we even use in blood cancers to suppress the immune response, are being looked at, but they don't kill it. They will treat the symptoms and perhaps reduce the severity of the disease, but they will not kill the disease per se. There is nothing that will kill the coronavirus other than the use of vaccinations where your body's own immune system is killing the virus. So the principle of vaccination is that you are giving part of a broken down virus. It's a bit like giving a rag to a bloodhound and saying, this is what you have to chase. Your immune system gets activated and then will pounce on it. So that happens when you get a vaccine as a child. Mothers give their child measles, mumps, rubella. Those vaccines stay with you for a long time. Some vaccines only stay with you for a short time, such as tetanus, where you have to be revaccinated. So it depends on the potency. The flu vaccine changes every year because the virus changes. And we may find that the coronavirus changes over periods of time. We're not sure. These are all the things we have to learn. But the vaccine is what is ultimately going to get rid of this and make it a controllable disease. And the time frames vary from 12 months, 18 months, 20 months is what I've heard. I think 12 months is the most optimistic, and I think we've got to think about those sorts of time frames when we talk about reducing the borders and lowering the borders. So America is in for a terrible storm, I'm afraid. There's no other way of looking at. It's going to be I would say, multiple countries in Europe, all through America, and that's going to prolong this virus infections because it will move from state to state. That's almost certainly what's going to happen. From there, it's going to mean that the virus is still in the world at high levels in a few months' time. If we can control our borders, we'll keep it out, and then it's a matter of looking after ourselves. The vaccine will come and we'll return to normal. So practically speaking, first of all, follow the current instructions. Staying in means staying in. We're all at risk of picking up this virus. The numbers are dropping and we should be very optimistic, and you'll hear and things will change on a day-to-day basis. That's great. I think if things are looking very promising, the disaster that was being faced in the UK is very, very unlikely to happen here as long as we keep going the way we are. Secondly, the treatments out there, there's not going to be a sudden snap treatment, I'm afraid. There's going to be some things that will help people get over the disease, but don't hope on an antibacterial. It's just not going to happen. Be patient. The borders are going to remain shut for a long time. Don't be planning holidays. It's just not, we just don't know. We're going to be an isolated country for many, many months, but locally we're going to be able to look after ourselves. So continue to look at getting the flu jab. It doesn't treat corona, but the flu will be out there. Fortunately, with social isolating, we should see less of the flu as well. There is a shortage. My patients are all saying, I can't get it yet. Just be patient and emphasize that you need to be prioritized. And again, please remain calm. We're in a much better understanding of this condition as we were 3 weeks ago. We're all quietly confident, but ultimately we all have to work together. Don't be scared. We know what we've learned from this is that that even having a blood cancer is not putting you at an enormous risk. You have to take precautions, but just be sensible and you'll be okay. So thanks very much, and happy to take more questions next week. Thank you for everybody who's joined in. Thanks, Miriam from the Snowdome Foundation. Thanks, Jan. Thanks, Vivian. It's good to have you all there listening in, and we'll get some more questions and we'll be back to you in the next week or two. Thanks very much. Bye.